The the leading reason to have surgery on your lower back is spinal stenosis in an age group over 50. So a spinal stenosis that we'll certainly talk more about is a very common problem, and there are a lot of surgeries that are done to try to correct this problem. Next slide. The patients that I see that have spinal stenosis or in their lower back, the lumbar spine, typically have pain that runs from the buttocks down the back of the legs. And this is usually made worse with walking, and it's relieved with resting. Many times the leg pain will actually get better if you lean forward, because that has a tendency to open up the channel for the nerves. We're going to talk more about this, but the problem with spinal stenosis is that the nerves in the lower back don't have enough room. So anything that, when you bend backwards, say such as going downstairs, that tends to close down that channel, so it would bring out the leg pain. If you lean forward, it opens up the channel, and many times patients will say that makes their legs feel better or their back feel better. And that's the thing we call the grocery cart sign. If a patient says that when they're shopping in the grocery store and they start having pain in their legs, if you just lean forward and lean on the grocery cart, it makes the legs feel much better. That's a typical sign of spinal stenosis. To understand spinal stenosis, it really takes an understanding of spine anatomy. And just to go over this, the spinal column has joints in the front as well as in the back, and this allows the spine to bend and move. If we didn't have these joints, your spine wouldn't be mobile at all. So you have the joint in the front, the disc or the spacer that acts as a joint in the front, along with two joints on the back called the facet joints, is what allows the spine to bend and move. Now, unfortunately, though, the aging process tends to affect those joints. And gradually, over time, what happens is the disc here flattens out. These joints get spurs on them, just like any other joint in the body. And in combination, that makes this channel much smaller. And what goes through this channel is the nerves in the spine that form the sciatic nerve, the big nerve that goes down your leg. So as long as there's enough room there, everything's fine. But then when the channel gets very narrow, as I say, usually it's a gradual process that occurs over time through aging. When this channel is small enough, it'll start pinching the nerves. Now, the back of the spine has a structure called the lamina, and it forms like a roof over the spine. And historically, when I started doing these operations almost 20 years ago, really the only procedure available to manage this surgically would be to do what's called a laminectomy, which means you remove this lamina, which is the roof of the spine. We'll talk about this more, but that's what's called a direct decompression as opposed to an indirect decompression. And nowadays, there's a lot of movement toward indirect decompression of the spine, which means the channel for the nerves is made larger, but it's not done by removing bone. It's done by recreating this height through the disc and also through opening up this channel here. So two forms of indirect decompression would be a device such as an ILIF, which would be inserted here to jack this space open, and by jacking that open, it also opens this channel up for the nerves very nicely. This is the area that becomes too small in spinal stenosis, because that's where the nerves come out of the spine. So a device that would jack this space open, or a device that would go back here to spread this area apart, would open that channel up. So those are forms of what's called indirect decompression. Let's go to the next. So things that can cause a problem and they can pinch a nerve are a herniated disc, the collapsed disc spaces, bone spurs, and then a situation where the vertebra shifts, something called spondylolisthesis, which is just a fancy word for the vertebra not lining up properly and being out of a line or shifting between the two vertebrae. Next slide. Can you do anything to prevent spinal stenosis? Not really, because it is an age-related process, and I'm not aware of any way to stop aging. Well, there's not a good alternative to that anyway. We just have to accept that. But there are things that you can do by changing your lifestyle that can slow down the aging process. A lot of people tell me I'm an exercise fanatic, but I do believe in fitness. I think it's very important. I think stretching is also important. I used to think yoga was somewhat hokey, but I've definitely changed my mind about that. I think yoga is a very good way to stay flexible. As our bodies age, we lose our flexibility. So yoga becomes, or any form of stretching becomes very important. Along with that, we need to try to maintain a good, strong core. Core is this part of your body. Everything here to here. That's very important when it comes to maintaining health of your spine. I can't emphasize enough how important it is to have a strong core. It also helps you with your balance to have a strong core. With most activities that you do, you can do much better through having a strong core. So what I tend to tell my patients is to try to stay flexible, be really consistent with doing core strengthening exercises, and try not to smoke, and try to maintain your ideal body weight, because smoking does accelerate the aging process of the spine, and it also interferes with the healing process. Anytime you do a bone grafting procedure, the outcomes are much better in patients who don't smoke. Next slide. The first line of treatment, though, for spinal stenosis is not surgery. I tend to try to get patients better without an operation if possible. And among those options, of course, exercise, physical therapy, short period of rest. Epidural steroid injections can be helpful. Usually they're temporary. Usually they don't last, but they can certainly relieve the symptoms for a while, sometimes as long as 6 months. And then other medications such as ibuprofen, Motrin, Celebrex. There are a lot of options there. But if the non-surgical treatment methods don't work, then that's when we start talking about surgery. And as I said a minute ago, there are options for fixing the problem. The problem being there's not enough room for the nerves in the spine. The spinal canal is just too small. So most procedures that we would use would involve making that channel larger through either direct decompression, which is a laminectomy, or indirect decompression. The traditional way has been the laminectomy, which involves going through the back of the spine, but as I said earlier, we now have options of going through the front of the spine or even going through the side of the spine, so we can come at the spine pretty much from any angle nowadays. So just to emphasize this point, decompression, direct versus indirect. Direct decompression is what you see on the right here. The removal of the bone, the laminectomy, which is done going straight through the back of the spine. The indirect decompression, you can go through the front, the back, or the side, and that involves jacking the space open between the vertebrae and spreading that area open. The reason we have moved towards some of these other procedures is that it's not always perfect to do the laminectomy, because doing a laminectomy alone many times creates a problem with instability of the spine, meaning the spine is too loose. So decompression can destabilize the spine, or it can take some of the stiffness out of the spine and make it too loose. So it's rare nowadays to do a laminectomy alone. Most of the time a laminectomy will be combined with a fusion. And this is a picture of a fusion done along with a laminectomy. This is the area where the bone's been removed. This is bone graft, and then these are rods and screws, something called pedicle screw fixation. And that works very well, but it does require a fair amount of dissection through the muscles. There's a fair amount of bleeding that goes on with that, and that is a very good option, but sometimes that's just a little bit too much, particularly in a patient who may have a lot of medical problems, where it would be very risky to have a lot of blood loss or to have a prolonged surgery, say a surgery that took several hours as opposed to maybe 1 hour, we needed to have another option. And just to define a fusion involves using bone grafting materials that go across the area of the spine where the decompression has been performed, and that is to get the two vertebrae to grow together and to have a bridge of bone that connects the two vertebrae. So instability is a problem if you do just the laminectomy alone without combining it with a fusion. But in many cases, the screws and the rods may be too much for a patient. So we needed something like the ILIF that would be a better fit for many patients. Next slide. So now we got a video that Monty's gonna get going here. This is the ILIF procedure. So this is the initial incision. It's usually a very small incision. Can everybody see that okay? And this is the back of the spine where some of the ligaments are being removed. This is the spinous process. This is the ligament that goes between the spinous process. These are what we call distraction pins that are put into the top of that bone, the spinous process, and it allows me to spread that area open and open things up while I'm doing the laminectomy. And this is just showing the spreading of that area. And just to orient you, this is the back of the spine. This is the lamina, and the nerves are just below that. So this part of the procedure is the direct decompression, the removal of a section of the lamina. And then this is the spacer that's put in between the spinous processes. This is the bone graft that I use. And by putting that in, it spreads the two vertebrae apart and opens up the spinal canal, and also locks it together and fuses it. This is the spinous process plate. And this can all be done through a much smaller incision than the procedure where you put the rods and screws in. That's a good question. The foramen is right down here, and by spreading this area open, you're through the indirect decompression. That's opening the foramen. This part right here, the direct decompression, opens it up partially, but down here is where the foramen is, so the indirect decompression is what opens that up. And this is what the last part of that was the spinous process plate over the bone graft. So the benefits of this procedure over the other procedure that I talked about where you put rods and screws in is that typically it is less blood loss, there's less dissection through the soft tissues, it's usually a one-night stay in the hospital. Hadn't really done it as an outpatient yet, but I guess that's possible. But usually patients stay one night, and it's a much faster recovery. So I wanted to tell you about a special patient, William Mitchell. He had problems in one of his legs due to spinal stenosis. He had a foot drop. He had a lot of pain and numbness in his leg. And on the next slide, I'll show you his MRI. This is a little bit fuzzy, but right in here is where he had really tight spinal stenosis. This is a side view. This is what's called the sagittal MRI. This is a cross-sectional picture. This is the spinal canal, and that is much smaller than it should be. He had severe spinal stenosis at that level. Next slide shows his x-rays. And he did also have a little bit of a slippage in there between, so there was already a little bit of looseness, and my concern